Alert Medic 1 respond. Box area 19-.
You're listening to the Alert Medic 1 podcast, the premier emergency medical services podcast with your hosts Mustafa Siddiq and Ken Sanner.
Okay, hello everybody. Welcome to the Alert Medic 1 podcast. It's your two hosts. It's Ken.
Hey, it's Moose.
And we are here with two awesome guests. We're very excited to have Dr. Anders and Kyle Fratta. They are both very much involved in pediatrics and some really cool programs going on here in the state of Maryland. So I'm going to let them introduce themselves very quickly. Dr.
Thanks,
Anders?
guys. Yeah, I am Jennifer Anders. I am a pediatric emergency medicine physician at the Johns Hopkins University. And in my spare time, I work for the state of Maryland as the Associate State Medical Director for Pediatrics at MIMS, the state EMS agency. And I am very excited about all things pediatrics and want to talk to you guys about a range of things that have to do with EMS for children. And importantly, Kyle and I are very excited to share with you a project that we have developed called the PD tree, or the pediatric decision tree.
I'm Kyle Fratta. I'm a third-year medical student at Campbell University. Before that, I was a paramedic in Baltimore County for about 6 years, and I worked with Dr. Anders at Hopkins on the PD tree project.
Great. So it is awesome to have you both with us here today. And we're going to kind of take the show in two directions today. The first part, we're going to just talk about pediatric calls in general, how we should respond to those, when should we stay and play versus load and go. And the second part, we're going to talk about that project Dr. Anders mentioned, that PD tree project. Now, as you all know, I don't disclose where I work, but what I will say is I had the opportunity when I was assigned to the training academy at my career department to have Dr. Anders and Kyle come in a couple times and talk about the pediatric decision tree, and it is an absolutely cool project. So I can't wait to get into that. My first thought with it was, I can't believe no one's done this before. Like, this is great. So we'll get into the nitty-gritty with that here in a little bit. But the first thing I wanted to talk about are pediatric calls in general. When we think about those as paramedics, as EMTs, pediatric incidents are one of the most stress and anxiety-inducing incidents that we can have. We get the jazz hands, we get shaky, our heart rates go up. Why is that? So I'm going to throw that to Dr. Anders and Kyle. What do you guys think?
So personally, I definitely agree with you. As a paramedic, that were definitely the most anxiety-inducing calls for me. And I think it's two-part. It's definitely a lack of training at baseline coming out of paramedic school and continuing ed. But also personally, from my experience, it's just a lack of seeing a lot of pediatric volume. And when we do see it, they're usually not that sick. So taking care of a very sick kid is 1 in 1,000 calls or so.
Yeah, I think that's certainly true. And you don't have to talk to very many EMTs or paramedics to hear that story told. And I think the data certainly bears it out. Obviously, EMT training is a limited number of contact hours, and pediatrics is a relatively small slice of the job. So there just aren't that many hours devoted to training. And even in a longer paramedic training program, it's just a small number of contact hours.
Do you think there's? I'm sorry. I was going to say, do you think there's a perception that, particularly in these critical pediatric calls, that these calls are more high stakes? Like if I have a pediatric and respiratory extremis versus a 50-year-old respiratory extremis, it may not. The 50-year-old may not elevate that heart rate and get everybody nervous, but the pediatric patient who looks like they're pre-code because they're having this horrible asthma attack, that seems to evoke a whole nother response.
I think that's definitely true, and some of it again goes back to just lack of exposure. You've run that call so many times on the 50-year-old, and the number of codes you run on 50-year-olds is so much higher than the number of codes you run on 5-month-olds, that just that worry about what's the worst thing that could happen, it's a lot more stress inducing with the small one than with the middle-aged guy, where you've got past experience to fall back on. Across the country, only about 7% of all EMS transports are children. And by children, we mean kids less than 18 years old. Less than half of those transports are young children. So what we would think of as real pediatrics, the single-digit ages. And then a tiny fraction of that, 3 to 4% of calls that are small children, a tiny fraction of those are seriously, acutely ill. So the numbers are small, and for any given EMS clinician, the frequency of exposure is going to be low, and it's really hard to train and feel prepared for rare events.
Yeah, I think that's very spot on and some really interesting statistics. How can the EMS clinician increase their comfort level with kids, especially sick kids? What's the best thing we can do? If we're not getting that hands-on education in our initial training programs, where should we turn?
So I'm actually going to back up one step. I think one of the really useful things to do is to get more familiar with healthy kids. So speaking back to that first question about why is this so stress-inducing, EMS clinicians, especially younger folks, tend to be male and young. And if you don't have kids at home, if you're not a parent yet, or if you haven't been put in the situation of doing a lot of childcare for young siblings, it can be really difficult to know what's a normal 5-year-old like. What is a 2-year-old supposed to do when they stub their toe? And the communication barriers and the stress of just having a healthy crying child in the back of the ambulance with you is going to raise your blood pressure. So having whatever exposure you can get to kids is helpful. The other things, though, you can do to get more exposure to sick kids would be to put yourself in situations where you can be with them. And I think wherever there may be opportunities for continuing education, whether that is didactic training or simulation-based training or actually getting more clinical exposure either in pediatric emergency departments or in I understand they're not as frequent as I wish they would be, but opportunities to go into a pediatric anesthesia suite and do airway management in children. Wherever we can get more exposures and opportunities for ALS providers especially, I think we can increase that confidence and increase that skill set.
That kind of brings up an interesting point, and it's kind of tangentially related to what we're talking about. It would be nice if we had more content opportunities that were like clinical hours, especially for stuff with kids, where instead of saying, okay, I'm going to go take this 8-hour class on pediatric emergencies, what I'm actually going to do is spend an 8-hour rotation at, a level 1 pediatric trauma center or a comprehensive pediatric center or something like that. And that's not, something that's really something we can accomplish here today, but it is a good thought, I think.
Yeah, so and that's what I was going to comment on. Like, so 100% full disclosure, even now that we're talking about it, there's like a little level of anxiety that, it just automatically comes up, right? So kids, when we're dispatched for the cardiac arrest, as we're talking right now, I'm thinking of calls that I've been on where I react completely differently when it's a 73-year-old arrest versus a 33-year-old arrest versus a 3-year-old arrest, right? And it's just that stress has created like a sensitization loop in my head. And the only way I can think about breaking that is additional training, right? And throughout the podcast, a bunch of episodes that we've recorded, a repeated theme keeps coming back, which is more education, right? And I'm going to go off on a little bit of a tangent here, but we're functioning as independent providers in the field. Our equivalents have a ton more training in the hospital, right? At a minimum, they're master's degrees as, physician's assistant or NPs. But we're arriving on scene and we are, we have these acute kids that are really sick. Of course, we're going to be, apprehensive of that situation because we don't understand what the patient is, right? Like we run the 50-year-old COPDer every shift, right? Or every trick. I can probably count on, actually, no, I can't. But it's a small amount of patients that I've truly seen that are really, really sick. And I think it just comes back to additional training. And yeah, you're right. I don't think we're going to fix. The Rome wasn't fixed in a day, but I think that's how we need to fix it.
Yeah. As much as I would love to see real robust opportunities for clinical shadowing and clinical time for all EMS clinicians, even in the pediatric emergency department and at a very high acuity pediatric emergency department like I work in, it may be once every 3 to 4 shifts that I even see a really sick kid. So I don't know that that's going to be a great way to ensure that we efficiently get the education that we need to deliver to the EMS clinicians. Because I'd hate to have somebody come and spend 8 hours with me, and the worst thing we see is one kid with a moderate capsular croup.
You just described my whole pediatric clinical experience. We didn't see. I don't think I saw one sick kid at Upper Chesapeake. I was all the sick kids I saw were when I was riding in Baltimore City.
And kind of on the lines of what Moose was just saying, or actually what you said, Dr. Anders, even if, though, we did a shift and the sickest kid we got was a moderate croup, that's still a higher severity of pediatric patient than most of us will see in a month, Oh,
absolutely. I think there's things to learn there. Sorry. And I really enjoy when we have paramedic students come and spend some clinical time with us in the pediatric ED at Hopkins, even just getting vital signs or getting exposure to kids that are moderately ill. You can see the benefit and how much it is adding to the way they're thinking about approaching and assessing sick children. So not to downplay the importance of that, but signing up to spend a shift with me and expecting that you're going to see even one critically ill child or code is a real crapshoot. So the way that I think we can make sure that our EMS clinicians get exposure to those sorts of things would be in simulation, when we can plan ahead and schedule to have a moderate fidelity or high fidelity situation happen. We have a variety of organized programs that are already doing that. In particular, the Pediatric Education for Pre-Hospital Professionals, or the PEP course, that the AAP and ACEP jointly endorse, is pretty well distributed around the country in almost every state. I don't know how many hundreds of courses are run each year, but it's some number in the hundreds. And we run them in Maryland on a semi-regular basis. I think those sorts of courses where you can get exposure to case-based scenarios and simulation training on the pediatric high acuity skills are really helpful. The other major program that is rolling out across the country, part of the EMS for Children federal program, is a state partnership in every U.S. state and territory. And one of their key performance measures that they've been tracking for the last 3 or 4 years is the establishment of what they call a pediatric emergency care coordinator in each EMS operational program. So in Maryland, we call our PECs pediatric champions, and they are point people to provide local educational opportunities, because in order to get this education out to the large number of EMS clinicians, we've got 20,000 EMTs and paramedics across the state of Maryland. I'm sorry, EMTs, CRTs, and paramedics across the state of Maryland. We need to bring those drills into every station and have them available where the clinicians are not expect that everybody's going to cycle through a classroom or a clinical shadowing opportunity. We've got to take the education to the EMS clinicians.
Cool. All right. So kind of moving on from there, we've talked about some of the anxiety that, these high priority calls cause us, which leads, I think, a lot of the time to load and go, even when that's not appropriate. So what I'd kind of like you to break down for us is, when should we absolutely load and go, and when should we actually stay and play and try to fix the problem, or at least stabilize the patient a little more?
So when I was thinking, the load and go versus stay and play, I think personally, a pretty large group of the children we take care of can be at least in some way addressed on scene. And looking through some of the past literature, especially between all kids and especially kids in arrest, really taking care of the kid at the site has been more beneficial in cardiac arrest and getting ROSC and getting good neurologic outcomes. And when you think about the number of calls we get, the highest probability is going to be a kid with a seizure or asthmatic, possibly some type of airway obstruction. And these are all things that we are capable and within our scope of practice to take care of at the scene.
Yeah, so that's what I mean, and we kind of talked about it before we started recording, but I think this is a discussion right now, right, at the state level, of what is there a set amount of time, and how do we break that that reflex that many people have to just load the kid up. I think it's a proven fact that we cannot do adequate interventions in a moving ambulance. Right, like whether it's compressions, whether it's starting an IV, any like ALS, higher level ALS goal, you're not going to be able to efficiently do and safely do, right? And I think back to calls that I've had where I've shown up and there's people there already, the stress of the scene is already up, and you have people that are carrying a kid to you that is in full cardiac arrest, right? And because of the culture, because of the quote-unquote accepted practice right now, I questioned myself of, hey, should I be moving right now, right? But no, I mean, the appropriate care is, if you all the literature shows, and I think practice has kind of moved, that if you have an adult in cardiac arrest, you are staying and giving them high-quality CPR until you get either ROSC or you hit a particular point. And please don't shoot me, Dr. Anders, but the physiology at this point doesn't change, right? A heart is a heart, perfusion is perfusion, right? Like compressions are compressions. Yes, I'm sure at very detailed things there are changes, but what I'm getting at is you should be showing up and starting compressions on these kids, right?
If there's one answer to your question, when should we not load and go, it is absolutely the child in cardiac arrest. A child in cardiac arrest needs their airway opened and some ventilation. Mainly by that, I mean bag valve mask ventilation and chest compressions. And they also need rapid access to epinephrine. So in my perfect world, every child in cardiac arrest is going to get an ALS response in fairly short order, have high quality CPR with ventilation, chest compression, get a first dose of epinephrine before the question of loading up even occurs to anyone.
And there really is research coming out to support that. And there has been for a couple of years now, correct? Like this is something that is kind of documented, that this is the best way to go with most of these calls.
There's really strong research on that. There have been a couple of really important studies come out in the last couple of years about out-of-hospital cardiac arrest and EMS care in children. So the first one was published last year and has really strong evidence that early epinephrine matters. So that was published in Circulation in 2018. Hansen was the lead author on that. And they found that early epinephrine, by which they defined as less than 10 minutes after arrest, was a strong predictor of better survival for both adults and children. When they broke down their subgroup into the two different age groups for pediatric patients, every 1 minute delay in getting epinephrine reduced the odds of survival about 9%.
Wow, that's pretty impressive.
I'd like to dive into the physiology of that a little bit, Doc, if you don't mind. So we understand that with adults, we hold off on that epinephrine because generally, a VFib or VTAC arrest is, we need the compressions and we need the defibrillation. But the incidence of VTAC VFib arrest in pediatrics is way less, correct? Yeah, and generally, if we do see it, it's probably a congenital heart defect or something like that, correct? I guess an outlier would be maybe a lacrosse goalie or something who got hit in the chest, right?
Komodo cordis.
Yeah, but apart from that, you're not going to see it. And to further on that point, these arrests are, and I don't know if this is true, but I've always been taught that generally pediatric cardiac, and Ken taught me, by the way, he was my paramedic instructor, so if this is wrong, it's his fault. If a kid is in arrest, generally you should be aggressively looking at the airway to see if it's an airway issue. Is that correct?
Yes.
Okay.
So for children, most of the time, cardiac arrest is an end process that started with respiratory compromise and hypoxia.
Okay.
As opposed to adults who are having primary cardiac events, ischemia, for the most part. In kids, once they arrest, the algorithm has still gone to the CAB and compressions first, but the airway is not far behind. So where we have the option for hands-only CPR in adults, the AHA does not endorse any compression-only CPR for pediatrics.
So do you think that again, like kind of diving into the physiology, obviously, epinephrine is the catecholamine that's working, to increase cardiac activity, right? But in pediatrics specifically, do you think its beta-2 activity because of a respiratory etiology has anything to do with, increased effects in kids? Or is it like, I guess we need to have, no? Okay.
No.
Okay.
It's an interesting question, and there may be something there, but you see ROSC within a matter of a minute or two. And when we use epi for kids in severe respiratory distress that are sort of respiratory arrest, those asthmatics that are going down the tubes, it just doesn't improve their respiratory status that fast. It's reasonably fast, but it's not instantaneous. The charge that epi gives to the heart seems to be an independent thing.
Cool. Thanks.
Yeah. Do you have anything else you want to talk about with before we jump into the PD tree?
No, I'm good. So fair warning, this is really going to tick you guys off. I think I didn't even know PD tree existed until Ken asked me if I wanted to do an episode on it. And I consider myself a well-versed, educated paramedic. And I guess I just never worked in a jurisdiction that used it. Like, I didn't even know it existed until Ken was like, hey, you want to do an episode on pediatry? I'm like, yeah, sure. What is it?
What the heck is that?
Yeah. So, I would
Fair
throw
enough.
it to the two of you basically like this. We have a listening audience around the country. So it's not necessarily just Maryland
And the world.
And the world. Yes, and the world.
I can show you the
Please.
stats.
I would like to see that. So how would you explain the PD tree, the pediatric decision tree, to the EMS clinician who is unfamiliar with Maryland EMS?
Absolutely. So the concept here is that transport destination matters. I'll back up a little bit and just give you a couple more statistics. EMS provides some sort of treatment or procedure to about 25% of pediatric transports. So that includes giving oxygen, doing an albuterol treatment, any kind of IV start fluids, medications, about 25% of the time. We've looked at Maryland specifically, and then similar studies in other states show approximately the same kind of rate. About 40% of the time, EMS transport bypasses the closest hospital and chooses another facility of a perceived higher capability level for a pediatric patient. So that means about twice as often as you give any kind of drug or oxygen to a kid, EMS is making a transport decision that does have impact on their care. And it matters where they end up, because if you go to a local hospital, you go to the closest hospital to the scene, and they're not able to take care of the child, they arrive, they get registered, they get that little wristband put on, they take a history, the nurses do their triage that takes about 25 minutes, it seems these days. And somebody comes in, finally says, oh, heck, we don't have the kind of surgeon that will operate on this kid's broken arm. We're going to need to call another hospital and transfer him over there. So they make phone calls. The commercial ambulance is arranged. It's going to transport the kid from hospital 1 to hospital 2. The whole process in a best case scenario is probably going to add 2 hours to the day for that family. That is a lot of time and stress where the kid isn't getting the care that they need. So wouldn't it be better if EMS had the transparent understanding of what is the capability at the various destination facilities that are feasible for them to get to? Not that anybody should be driving across the country with a kid, but if you could go 5 miles further to get a kid to a place that can give them definitive care, wouldn't you rather do that as an EMS clinician?
Absolutely.
And so we started from that point of view.
Absolutely. I think that's an awesome concept. And this actually goes into something I want to talk with you about one day, Moose, is how important it is for a paramedic or an EMT to understand what definitive care is for specific issues. That way we make these more educated choices. But in the lack of that ability or knowledge for some people, I think having something like an algorithm or a decision tree where you can work down and say, okay, this patient meets category X, we need to go to the comprehensive or the specialty center. I think that is just it boggled my mind. Like I said at the beginning of this, such a great idea. How did no one think of this before? Which kind of brings me to my next question. Is there anything else like this out there, or is this like really a novel idea that you guys had?
So it's not exactly a novel idea. It's been going on in EMS for a while, especially when you look at stroke centers and STEMI centers. There's even people who do direct transport protocols for geriatric patients and psychiatric patients. It's just never been extrapolated to pediatric patients.
Right, and that's what I meant in regards to peds. You know, it's like we've always had this for trauma, and you know we have other specialty centers, but I guess not always had it for trauma, but you know, over the past 10, 15 years, it's been around. Just the idea of having something like this for peds, it's just such a great idea. I
mean, to me, I'm newer to the game of EMS, but just makes sense.
Yeah.
Right? If you have a STEMI patient, you're not going to take it to the non-STEMI capable hospital, right? So
right.
I mean, it's really cool that a system like this exists. If only I worked in a place that used it.
I think part of the delay is that with a STEMI patient, those patients are pretty likely to have serious outcomes, either death or long ICU stays. Similarly with stroke patients and with high mechanism trauma patients. And so it's not difficult from a research perspective to prove that this algorithm for direct transport saves people's lives, or it makes significant difference in the neurologic status of stroke patients leaving the hospital if you can get them to their definitive care faster. Kids, fortunately, are pretty robust, and even very sick kids are able to make really good comebacks. And so it takes a very massive sample size to prove that such a transport protocol would make a difference for pediatric mortality. Mm-hmm. Okay. And so part of the issue why this hadn't been attempted, I believe, before, is that it was considered to be low stakes. So if you take a kid to the closest hospital and it needs to have interfacility transport, what's a couple of hours? It's no big deal. He's got a broken femur. He can sit at that hospital. He's not going to die of his broken femur, and they can do an interfacility transport. But when we tackled this project, I think the compelling argument that we were able to make is that it does matter. It's not just about whether people die or not. It's about how much stress and strain you've caused them. It's about how much you're costing the medical system by this trip to an emergency department and all of the resources that went into that local emergency department visit that didn't actually accomplish the goal of taking care of the kid's broken femur. So that was time and energy that all of the staff at the first hospital put in. It was time and energy that the family invested in that visit. And then you just have to pack up and do it all over again. And that's a harm. We also know from looking at the data that kids are less likely to get pain medication if they're taken to hospitals that are not really comfortable dealing with them. So kids with serious orthopedic injuries that go to kind of local hospitals and then get transferred to a definitive care site get less pain meds than kids that go straight to a site that is comfortable and capable of taking care of their injury. We know that kids get duplicate x-rays, they get duplicate lab draws. Those things hurt. Radiation has some cumulative negative effect. It's not life or death, but it's real and it's measurable. And if we can prevent those harms by giving EMS the tools to know with this kind of condition, hospital B is a better choice than hospital C, why wouldn't you give EMS that knowledge and a tool to do that?
Absolutely. And, in that same vein, on kind of like the human side of it, there's a financial and an emotional impact for the family as well, when you're going watching your child suffer and wait at one hospital that can't do anything. Then the private ambulance comes and takes you away. And yeah, it's a whole thing. So yeah, I definitely think that's some really great points that you make there.
So what's the outcomes? Like, what has there been any quantitative research that you all have conducted after launching this? Like, how's it going?
I cannot tell you that yet. We are still in our pilot year. So we launched the PD tree in 2018, but because of some issues of Maryland changing over our electronic medical record that's used by EMS, we didn't get universal data collection until the end of 2018. So we are in the tail end of our 12-month pilot phase. And at the end of this calendar year, we will have our opportunity to crack open the data and see if those bypass and transport patterns have changed and really look at what the impact has been on kids.
Okay. And another PD tree question for you.
Yeah.
Could you kind of break down the categories or levels of facilities available for the EMS
and we
clinician?
can put up I'll put a screenshot of the protocol too when we publish the podcast.
Oh, that sounds terrific. Kyle,
okay.
Do you want to take this one?
Sure. So we have broken down hospital availabilities from specialty and trauma centers as one group, comprehensive centers as another, regional, and we also have on the tree the closest facility for certain issues that need to just go directly to the closest facility.
Okay.
So actually, Jen, could you take this over? I don't have the notes for the specifics.
Oh, nice.
Sure. So the way we defined hospital types was hospitals that are designated trauma centers, designated specialty care centers, like burn centers. And in Maryland, we've got hand centers and eye centers. We've got all kinds of centers. So there are certainly patients that are best served at those trauma and specialty centers. The sort of universal categories that we also laid out were comprehensive pediatric centers, which we defined as places that had pediatric ICU capability, regional pediatric centers, which are defined as those that have pediatric inpatient units, or they have a 24/7 board certified pediatric folks in their emergency department, and then local pediatric receiving facilities.
Okay. Very good. Thank you. We're kind of looking at your protocol right now, just going through it. And, one thing that strikes me is that it's actually spelled out under these levels of care what sorts of patients need to go to what kind of what kind of facility. So, you have for the closest ED, you have stuff like cardiac arrest, can't establish an airway, stuff like that. Specialty center, you have the stuff you mentioned, cardiac arrest with ROSC, eye injuries, hand injuries, burns, trauma centers, trauma category patients. One thing that I may have missed, did you mention the patient's medical home facility?
I did not, but we did. That was felt to be really important to include, that if a patient has a chronic condition, that they need specialty care for that condition to get them to their medical home. Obviously, there are kids that have epilepsy and they've got a neurologist at the big hospital in Baltimore. But if what they have is a laceration on their knee, you don't have to drive them all the way to Baltimore for that.
Right.
But if they're having status epilepticus, maybe they do need to go to where their neurologist is.
Right.
So it does direct a kid having an emergency related to a chronic condition at a specialty center, that they go back to where their specialist lives.
Cool. And I'm not going
medical
to
home.
read the whole thing, but just to give
we'll post it. We'll probably do a
Yeah.
screenshot of this and we can post it. Is that allowed? I don't know if that's allowed.
I don't know.
Whatever.
Well,
It's public.
For the listener, comprehensive care stuff like DKA, altered mental status under 2 with no seizure disorder, joint injury with deformity, long bone deformity, and regional is stuff like ALTI or BRUI, seizure requiring medication administration, stuff like that. So like I said, I don't want to go through the whole thing. But it's pretty well thought out and spelled out. It's very easy for a paramedic or an EMT to look at this and say, okay, I see where my patient falls on this.
And I mean, when I look at this is what I want to look at 2 a.m. with a really sick kid, right? It's my ninth call of my 24-hour shift or 12-hour shift, or 14, I guess, and I need a protocol that is literally this, and it's really good to see. I do have a few questions, and just anecdotally, some of the experiences that I've had as a paramedic, where, especially where I used to work, and it kind of ties into what you said previously, Dr. Anders, of the tax that it puts on the system, but which some people use as an excuse not to transport to definitive care. But when you take into perspective the larger effect it has on the medical system, and I can explain that a bit. So, example A, you have a 7-year-old who has a history of epilepsy, right? And they're seen at Hopkins downtown in Baltimore, but you are 2 hours away. I can see a system, an EMS system, telling that person, no, take that kid, they're stable, take them to the local hospital, because there's not a lot of ambulances here, and we can't take you out of service. But on the larger scale of things, now the definitive care, that kid shows up to the hospital and he goes into status, right? The larger load, right, that it puts on the EMS system, not only the EMS system, the healthcare system as a whole, when we're looking into the local, the community hospital that may not be able to provide the best care, that transfer process, and the repeat of things that, like you mentioned, I think EMS leaders that are listening to this podcast should really take that into effect, because honestly, it didn't occur to me until you said it. Right? Because I think in EMS, we kind of seem to operate in our own silo and don't really consider the rest of medicine. But when you consider something like this, you truly are doing harm to your patient if you're not taking them to the appropriate, center. And that's what I mean. I'm like fascinated by this. I think every jurisdiction should be using this.
Yeah. So when we designed the PD tree, one of the major points was to try and balance what is best for the patient and what is best for the EMS system and the hospital system in a larger picture. So in the PD tree, there are certain stipulations which in the current model are left pretty vague so that this PD tree can be generalized out because, in Baltimore, the transport time between a comprehensive facility and your local facility might be 5 to 10 minutes. But if you go out into a rural setting, it might be much, much higher than that. Take a lot longer to get to those specialty centers. So we're not trying to eliminate interfacility transport or commercial transport. We're just trying to balance what's best for the patient. And in developing that PD tree, we tried to we searched the evidence, tried to make it as evidence-based model as we can to find exactly who's going to benefit from going to that comprehensive facility. Not everyone who's like a little bit back and forth. Should this kid go to a comprehensive? Should they go to a close facility? Needs to go, but the kids who need to go, we're trying to siphon out who's going to benefit from going.
And to kind of speak to how comprehensive you guys were in creating the pilot program for this, you actually set this up that it's being trialed not only in an urban jurisdiction, but also a suburban and a rural jurisdiction. So you can really see the effect on the different communities across the state.
Right. We thought that was really important to look at what the impact is across these different types of geographic regions. And so we have a large urban jurisdiction. We have a very large suburban jurisdiction that has much longer transport times and transport distances. And then we have a very rural jurisdiction that has a total of about 200 pediatric transports for the whole year. But from those three locations, the scene, the resources are very, very different. But when we looked at how they were using pediatric bypass in our pre-pilot test phase, so before the PD tree existed, across those three jurisdictions, about 50% of kids in our rural county and 50% of kids in our suburban county were bypassing the closest facility. And in our urban jurisdiction, there was a much lower rate of bypass, mainly because in our urban jurisdiction, we have the pediatric specialty centers really concentrated. They exist in the city. They don't exist out in the country.
Yeah.
Right.
I always say that Maryland has 5 regions that are 5 different states. You can drive an hour and you're in a completely different part. Area.
It is one of the few. Sorry.
I want to reinforce that you've raised some really good points. Number one, that I know that jurisdictional officers are going to get palpitations with any kind of protocol change that suggests we want to use more resources. But in the current system, before a PD tree exists, before there is any kind of evidence-based guidance for where to take your pediatric patient, we're asking our EMS clinicians to make those decisions and make that judgment in the back of an ambulance. And I think by and large, they have great judgment, but we're asking them to go in blind and make their best guess. Mm-hmm. And so right now, across the state of Maryland, about 40% of the time, our EMS clinicians are deciding to bypass the closest hospital. And across these 3 jurisdictions that we currently have our pilot test going on, it accounted over a 1-year period of 1,000 extra hours of EMS time for the bypasses that they are doing without any kind of protocol to guide it, just using gut instinct. Well, and I don't know whether that number is high or low, should be higher, should be lower. That's our benchmark for what the world looks like before the PD tree was put into existence. But I do know that's a significant amount of time and resource use to be doing without any kind of oversight or guidance for it.
Yeah, and I mean, I think we've also stressed on the podcast the idea that we need to make the system robust and fix latent issues of the system, like that and have medical physician led guidance whenever possible, right? And evidence-based guidance. It's awesome to hear that. Honestly, it's great to hear the process that you all went through. I think
I think there's two significant strengths of the PD tree, the pediatric decision tree. The first is that it's evidence-based. We looked at all the published literature about what conditions are most likely to need secondary transport, so to need an interfacility transport after EMS has delivered them to a first hospital, and what conditions is there a medical impact where we can show that kids have longer ICU stays or where there is an increase in morbidity, mortality. And so we chose those conditions to populate the PD tree. We didn't just pick things that, I decided were a good idea. We went from where there was evidence to show that this destination decision has a real impact, a measurable impact on the patient. And then we assigned them to the different levels, and we went through every hospital across the state of Maryland and assigned those hospitals to those levels and put in our tool for the Maryland clinicians that are using this, what hospitals in your neck of the woods meet this level of capability, that level of capability. Because you don't know, just because a hospital has a billboard by the highway that's got a teddy bear on it and says, "We love kids here at local town hospital," or because you roll in and they've got Mickey Mouse stickers on the wall, that doesn't necessarily translate to them having pediatric anesthesia services that are going to take a kid to the operating room. And so we were asking our EMS clinicians to make these judgments based on completely unsupported evidence. It's basically how nice the triage nurses were when you rolled in. If they scowled at you and you brought a kid in, you're like, well, I'm not going there again.
We won't get into that.
Hey, the pediatric nurses are usually pretty nice.
Or if it looked child friendly. And so what we want to do is bring transparency. Like the EMS clinicians should know this hospital is a stroke hospital. You can bring your stroke patient here. Mm-hmm. And they should know this hospital has the facilities to take care of kids through the spectrum of care, not just stabilize them in the ED, because every ED across the state of Maryland is totally capable of stabilizing a kid. But are they going to be capable of admitting them when they need to be admitted or doing the procedure that they need to fix their broken bone? Mm-hmm. And I want to put that information into the hands of our Maryland EMTs and ALS providers.
Okay, cool. Moose, do you have anything else?
So I have a few pediatric related questions that I've always just been burning. They have nothing to do with Peditree.
All right, shoot.
If they're random, then don't worry about it. I'll just edit this part out. So number one for me is pediatric pain assessment when they can't talk to me, right? And I feel like kids are just crying all the time. I don't have kids. I have a nephew who I hang out with for an hour and then I give him back. So do you have any pearls for the average EMS clinician who's you have a crying kid, but you don't know how much pain they're in? What are some tools to do that?
Oh, wow. That is an excellent question. That was my actual first area of research inquiry back when I was a pediatric ER fellow back in Chicago. There are not great tools for the child who isn't able to communicate verbally. Basically, we have two options. One is to make your best guess, and the other is a scientifically validated tool called the FLAC scale. It stands for face, legs, arms, crying, and consolability. And it's like an APGAR score, so you get 0, 1, or 2 points on each of these 5 different areas, and then you add it all up, and you get a score between 1 and 10. You need algebra and a calculator to figure this thing out.
Yeah.
It never struck me as being something that was useful for emergency department use, let alone for EMS to use. So my best answer is if the child has an obvious traumatic injury, if they have a burn and they are crying, give them some pain medicine. You are not going to harm a child with one dose of a narcotic. If it turns out to just be a sprain, but they were screaming and crying, no harm, no foul. So in cases of trauma, I would definitely err on the side of treating any kind of crying as potentially painful. Sorry.
I was just going to ask your opinion on intranasal fentanyl for pediatric patients.
I am a huge fan. In fact,
Awesome.
We changed the Maryland protocols this year. I'm very proud that I went to protocol committee and said across Maryland, let's make fentanyl our primary narcotic pain medication, and morphine was bumped back to optional status because we saw across Maryland that in jurisdictions that had fentanyl, when it was still an optional drug, about twice as frequently people were getting a narcotic pain medication in those jurisdictions compared to the ones that had morphine only.
I remember
having to start an IV is a huge barrier to getting pain medicine into a patient, especially a pediatric patient. So the ability to do intranasal fentanyl is a dramatic improvement to giving kids initial pain control.
So you've alluded to two other questions that I have. I have a total of four, unless I think of something else. So first, access. Any pearls for pediatric access? And I think of calls where it took three of us, right? So any pearls with that? Getting vascular
I am
access?
the wrong person to ask.
Fair enough.
I usually turn it right over to an experienced nurse or paramedic.
Fair enough. Kyle, you got anything?
I wish I could help you out there, but I'm in the same boat of asking that same question.
Fair enough.
Sometimes it's just really difficult.
Yeah.
And so where we can and give medications by other routes, we should. So the most common medications and the most important things I think we can do, certainly these are the three most common drugs given in Maryland. Number one is midazolam for seizures, can be given intramuscularly. Get the drugs in as an injection, and don't worry about the IV start. For epinephrine in cardiac arrest, put in an IO and push that drug, and don't worry about IV start. And for narcotic pain medicine, you've got the intranasal route for fentanyl.
The going on to pediatric dosing, any I know with like things like Hantevi coming out and stuff like that, any preferred strategies that you prefer for EMS?
I don't have a particular strategy that I would promote. Certainly having some kind of peripheral brain is incredibly important. I don't carry all those drug doses around in my head, and I don't rely on mental math to do my dosing. So in the hospital, we have a big binder in our code room that has a page for every kilogram of weight up to, I think, 20 kilograms, and then it goes in 2 kilogram increments after that. And we flip open to a page, and it tells me the dose of midazolam for a patient of this weight, and the dose of epinephrine for a patient of that weight, and a dose of atropine for a patient of that weight. And it goes through the 20 most frequently used medications in our trauma and critical care bays. The high acuity patient who needs emergency drugs is not the time to be fiddling around or trying to do stuff from memory. Yeah. So I'm familiar with the Hantevi product, and it's a commercial device, so I'm not allowed to have any official opinion about it from my position at MIMS. But several Maryland jurisdictions are using it, and I've certainly seen plenty about how it works from other sort of national sources. And whether it's that or there are free apps that are available locally, the Children's National Medical Center has an app that is free to download and use. Other kind of pocket cards, whatever sort of peripheral brain somebody can access, that is the way to go.
Cool.
Do you have anything that you use, Kyle?
No, I don't, but I definitely want to parrot that. I remember, especially as a young paramedic, always feeling very pressured to know this stuff off the top of my head, and being between my own pressuring myself and some of the older paramedics. But like she said, it's not the time to be trying to pull this out of your memory. It might feel awkward pulling out a calculator or pulling open the book, but it's the best for the patient.
Mm-hmm.
I feel like I've had a couple megacodes with physicians where they throw like random like SVT in kids, and they're like, and then they like throw them into arrest, and you're like not supposed to pull out your protocol. But no, I 110%. So I have a protocol on my phone, and when I have had to dose, even if I think I know the dose, I always verify via calculator just to ensure it. Mm-hmm. The last question that I have is regarding pediatric EKGs. I know that there's a ton of different, and so I'm a huge fan of Dr. Matu at university. I like follow his like weekly podcast, and he's always, and he doesn't talk much about pediatrics. So I just wanted to, and I'm not looking for like specifics, but just in general, what are some practices that if you're getting an EKG with a pediatric, what are some different things that you do as a physician when you're processing the information from the EKG that you can disclose to like the average paramedic who looks at an EKG and sees something and he's like, oh, I feel like that's not normal, but oh, my kid's 7, the patient's 7 years old.
Yeah, EKGs are not a major part of our practice because kids very rarely have ischemia. And when they do have cardiac arrhythmias, they tend to fall into a narrow range of possibilities. Adults with their old sick hearts that have various old ischemic injuries do all sorts of crazy things and have all kinds of crazy patterns. For kids, pretty much we are going to look for SVT, look whether there's a sinus rhythm or not, and then for the child with an irregular rhythm, try to classify them into broad categories. Okay. Whether it's wide complex or narrow complex, whether it is a bradycardia that is sinus or non-sinus, and then we aim with broad strokes with the drugs. The kinds of interesting, highly important decisions to be made that Dr. Matu is focused on in adult cardiology just don't really exist in pediatric cardiology.
Gotcha. And the reason I ask that is because one kid in particular that I had, family would call every couple of weeks, and there was known that there was something wrong with him, but at the period of time where I first started having him, they didn't know what it was, and they had never caught it. Apparently, a hospital had never caught it on EKG. And he had a baseline weird rhythm, and it was a sinus rhythm, but that's why I've always wanted to ask a pediatric physician that. So I'm glad I got to ask it.
So two take home points that I'll give you is, number one, don't stress about it, because none of us are that good at pediatric EKG reading either. Unless you're a pediatric cardiologist, nobody feels like they are a champ at pediatric EKG reading. And number two is there are a lot of conditions that kids will have that arrhythmias come and go, and being able to grab a rhythm strip and hand that over at the hospital may be the only thing that the cardiologist has to go on. Gotcha. And they'll have to arrange to go to the cath lab and do some sort of electrophysiology study, and having even that little 6-inch strip of monitor strip from EMS has sometimes been the only bit of clue that we have. So it is extraordinarily valuable to try and capture what you can and give that over at the hospital. So
cool.
Good. I'll shut up now.
No, you're fine. You're fine. Dr. Anders, Kyle, do either of you have anything, last words of wisdom you want to leave us with? Anything?
The last thing that I had wanted to say, and possibly, I don't know how editing works, Mustafa. Hopefully you can maybe edit in elsewhere, is the PD tree, the pediatric decision tree that we have created is actually freely available to the public already. It is supported with a web page that people can go to if they want to find out more about it at pdtree.org. And we have a mobile application, so you can download this to your phone. We have an iPhone version and an Android phone version, and it will work wherever you are across the United States. It is populated so that it will tell you what type of hospital to go to, even if we don't have any hospitals in our database for the state that you're in. If you are in Maryland, one of our surrounding states, or Austin, Texas, we have populated it already, and we're looking to add more states to that list over the next couple of months. And so you can go to the app store that works for your phone and just search for PD Tree, all one word, and it should pop up there. Cute little icon with a tree.
And we can link it on our page when we publish
super.
it. Yeah,
That would be great.
We'll link it. Yeah, no, I'll just have to put that down as a reminder. Yeah.
Okay. All right. Kyle, you have anything you want to leave us with?
No, thank you so much for having us on.
Thank you both
Yeah,
so
thank you
much
so much.
for coming on. This was an absolutely awesome interview. I think it was you guys were great. So thank you everybody for listening to the Alert Medic 1 podcast. Don't forget to check out our website, www.alertmedic1.com. We have lots of content on there, lots of articles. We try to push out new content as quickly as we can for you. Check us out on Twitter, alert_medic1, at alert_medic1, Facebook, alertmedic1. Please leave us a rating, subscribe to us on your podcast app of choice, leave us a review, and we'll see you all next week. Have a good night.
You've been listening to the Alert Medic 1 podcast, the premier emergency medical services podcast with your hosts Mustafa Siddiq and Ken Sanner.